Hello, good morning. Thank you for giving me this opportunity to present at the ESGE Congress. I will be presenting to you the challenges of managing asymptomatic thickened endometrium in postmenopausal women, a systematic review. No disclosure of catastrophe declared. Some background facts. According to the global cancer statistics, the worldwide incidence of endometrial cancer has increased in 23 out of the 43 countries around the world. The International Agency for Research on Cancer has predicted a 50% rise by the year 2040. It is well known that abnormal vaginal bleeding is the most common symptom of this troublesome gynecological malignancy. With this background, let's review some key facts. We know that women with postmenopausal bleeding have a 5 to 10% risk of having an underlying endometrial cancer. We also have clearly defined protocols for evaluation of women with PME and thickened endometrium. However, it is estimated that up to 15% of endometrial cancers occur in the absence of PME. What we don't know is that at or above what threshold of endometrial thickness should we evaluate women with an incidental finding of thickened endometrium in the absence of PME. We believe that the burden of this clinical dilemma is underestimated, and it is at a rise now due to widespread use of TBS or various other indications like urinary symptoms or pelvic pain. This lack of consensus among gynecologists with regards to the management of these women, the American College of Obstetrics and Gynecology recommends an individualized approach based on patient characteristics and risk factors. In comparison, the Society of Obstetricians and Gynecologists of Canada recommends universal evaluation of women with endometrium measuring more than 11 millimeters. In the NHS England, different hospitals use various cutoffs of 4 millimeters, 8 millimeters, or 10 millimeters, while in the NHS Scotland, they follow the PME bleeding pathway for these women. With this background, we formulated a research question, which was to determine the optimal endometrial thickness threshold that discriminates normal endometrium from endometrial atypical hyperplasia and cancer in asymptomatic postmenopausal women with an incidental finding of thickened endometrium. The electronic database was searched without attaching any temporal limits. We completed all our searches in December 22 and registered our meta-analysis with Prospero in June 23. We included studies on asymptomatic postmenopausal women where transvaginal scan was used to diagnose thickened endometrium, our index test, and endometrial biopsy was used to diagnose endometrial hyperplasia and cancer. We excluded case reports, conference abstracts, non-English articles, and studies where women were on drugs with no effect on endometrium. We followed the search strategy and shortlisted 13 articles for our meta-analysis as depicted in the PRISMA flowchart. The selected articles were assessed for risk of bias using the quality and prognosis study assessment tools. We had 4 high-risk studies, 4 moderate risk, and 5 of our studies were low risk. Our aim was to form a formal quantitative synthesis and generate a receiver-operator characteristic curve. Of the total 13 studies, the pooled prevalence of endometrial hyperplasia and cancer was 3.5%. Amongst the 13 studies, 8 evaluated a single cutoff, 3 evaluated multiple cutoffs, while 2 just reported mean endometrial thickness without really performing a statistical analysis. There was a wide variation in the cutoff suggested, ranging from 6 to 13 millimeters. The main challenge that we faced was a diversity in reporting of results. While some reported the area under curve, while others reported positive and negative predictive value. There was also, most of the studies were retrospective, that's 8 out of 13, and a limited number of high-quality studies. We consulted 2 different statisticians who both acknowledged that selective reporting of thresholds is a common problem in diagnostic accuracy studies, and they suggested that we obtain primary data from the authors. Since then, we've managed to obtain data from 4 studies, including 440 patients. But is this sufficient for meta-analysis? We are liaising with the statisticians to provide this for us. To conclude, we are planning a multi-central prospective study to facilitate development of evidence-based guidelines to inform clinical practice. Thank you for listening to me. I'd like to thank my mentor, Mr. Ewies, and my colleague Shahin, who's an equal contributor to this study. What questions do you have for me?
Thank you very much. So what should be the cutoff point? What do you
That is $1 million question. It's not difficult to perform an endometrial biopsy. We can do it with a pipple, we can do it with a hysteroscope. It's very commonly available. But the question arises when we have women, with multiple comorbidities who may not have this done in an outpatient setting, and then we need to subject women to general anesthesia to do this, and that can prove risky for some women. So essentially, that's the reason that we want to do a study to find a cutoff to give us an answer to this.
Yes, but according to at least what I remember, in order to be almost sure that she has cancer, it should be more than 20 millimeter in thickness. And then probably the risk increases after 10 millimeter, really.
Yes,
so
actually, yeah, from
I
the
don't know if it
guidelines.
is 4 millimeter, if it is really worth it.
So, like I said, that there's no universal cutoff. Like in the UK itself, in the NHS England, in Birmingham, where I work, in and around Birmingham and West Midlands, there are 4 or 5 different tertiary hospitals, and each of them uses a different cutoff. So we don't have an answer to this, and that's what we aim to find out.
Okay. Thank you.
Anything else?
Any other question? Yes, please.
With